righty. All right. Hello, 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 my friends. It's Jill Osborne from the IC Network. It is Sunday, July 31st. I said I was going to be off all the month of July. However, I'm feeling better. I was on voice rest. I'd hurt my throat very, very badly. And so now things are looking up. It's summer, and I know some of you need support. I'm getting lots and lots and lots and lots of phone calls. Hello, Jennifer from Texas. How are you today? Hot down there, huh? What's the weather like? So let's see here. Hold on one sec. So we are live on Facebook. We are live on YouTube. Hello, Facebook. Hello, Facebook. Hello, Barbara. Nice to see you, hon. I hope that you're doing well. I hope you're having a good summer. It is fire season again here. We got a big whopper of a fire up north of us at 30,000 what's it, square miles in 24 hours. We're having fires every day. We had a fire 2 miles away from us last week. Not fun. Not fun at all. Anyway, hello, Debbie. Hello, Sylvia. Nice to see you. Hello, Becky. So let me introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the United States. Close to being in the world, maybe might even be in the world now at this point in time. I'm not sure what the German ICA is doing. They were ahead of me. My purpose in doing these meetings is to educate you, inspire you, give you some support you need, and then give you the necessary kick in the butt to get back to your doctor with a better set of questions. Because a lot of you are still operating under the old assumption that IC is an incurable bladder disease when it is not. And our new AUA guidelines released 2 months ago very, very clearly say that this is a pelvic pain syndrome. This is all about cause and effect. And we have to be narrowly focused on underlying cause because the bladder can be victimized by many different conditions. Here, hold on a sec. I got to clean up my desktop here real quick. Facebook, how are you guys doing here? I can't, let's see here. Debbie says her IC is very, very bad. I'm sorry to hear that, hon. Facebook, can we just do a check-in real quick? Can you guys just say hi? Because we had quite a few people and then we lost quite a few people. I'm not sure why. So anyway, I really want to focus on the concept of cause and effect today. Normally I do these meetings every Sunday. We simulcast live on Facebook and YouTube. I did have to take a month off for voice rest because I had some dental work that then infected my vocal cords. And they're still it's way, way better, but it's still a little bit of an issue. So I'm going to go as long as I can. Let me get YouTube all straightened out there. So cause and effect. A lot of you spend your time chasing your symptoms, and that is a mistake. I'm filming a lot of videos right now. I was filming yesterday. I've got our new GSM video up. I've got our new AUA guideline video up. You're going to see a lot more videos coming from me. You have to understand that you could chase symptoms for the rest of your life using completely inappropriate medications that will never make you better. And when we think about the typical IC patient, for most of us, we think we have had an infection, but our cultures come back negative. We do more. We do long-term antibiotics. Many of us have done long-term antibiotics. Many of us have had very fancy urine testings. And inevitably, for the great majority of us, there's no infection to be found. And so at some point in time, somebody says, hey, I think you've got overactive bladder. Then somebody else says, hey, I think you've got interstitial cystitis. And you want to get better. You take the diagnosis of interstitial cystitis. You're scared. You don't know what the hell this is. They give you the diet. They give you some meds. And you go home and you do everything. You do everything they tell you to do because you really want to get better. You want your life back. I was working with an older patient last week who this exact same thing, she was devastated by a diagnosis of IC. She truly thought that the rest of her life was going to be tied to a restroom. And that could not be farther from the truth. What we have to do now is we have to get to a more individualized diagnosis. We are no longer accepting interstitial cystitis as a bladder disease diagnosis. Why? Because structures and other things can cause IC. I've worked with a number of patients in the last couple of weeks who have had endometriosis on their bladder, which is typical. A number of patients, again, who have muscle issues, they've got a bad hip, a bad SI joint, et cetera, et cetera. But if you watch the GSM video I put up, I really grieve for the millions of women who were told that they had an incurable bladder disease when in fact it was simply estrogen atrophy. If your symptoms started as you got older, your 40s, 50s, 60s, 70s, you had no previous history of bladder issues, or they started after hysterectomy, total hysterectomy, where they took your ovaries, or they started after using Lupron, which induces a chemical menopause for patients who have endometriosis, or even if you started a new birth control pill or a birth control method. What is the commonality in all of those? Estrogen. Estrogen. That your bladder, for women, the bladder needs estrogen to produce that nice, thick coating of mucus. And because your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. And the purpose of that mucus is to act as a barrier. It protects the skin. It protects the skin from any irritants in your urine, and it protects your skin from bacteria. It makes it harder to infect you when you have a nice, thick, robust coating of mucus. So your bladder is slippery on the inside. Your bladder is a mucous membrane organ. Your urethra is a mucous membrane organ, just like your vulva, vagina, and your mouth. It is meant to be moist. But as many women can attest to, that when your estrogen levels drop, what happens? Your skin starts to get dry and it gets thin. And thus, your bladder's ability to defend itself is now greatly compromised because it does not have the estrogen to produce a nice, thick coating of mucus. Now, that is not a freaking disease. That is not a disease. That is estrogen atrophy, and there is a very clear treatment pathway. Treatment pathway number one is topical estrogen. Now, Lisa here on Facebook says, but what if you've had breast cancer and you can't take estrogen? Well, Lisa, if you look at the research, I want you to, if you can, take a moment to watch the GSM video I just put up on our YouTube channel and on the IC Network website. What the research shows is that oral estrogen that you swallow by mouth, is absolutely linked to an increased risk of cancer. Because when you swallow it, it is absorbed into your bloodstream, it is distributed throughout your body, and yes, it goes to places it should not go, and it can cause, it can be associated with an increased risk of cancer. However, topical estrogen, which you just put on the skin, stays in the skin. It does not move to any great degree throughout the body. It stays in the skin. And what that research shows is that topical estrogen is stunningly safe and effective, even for patients with a history of gynecological cancer. But don't believe me, you need to read the research too. And so if you Google topical estrogen safety, you can look at the research yourself. 10 years ago, 15 years, 20 years ago, there was a tremendous amount of fear about estrogen. And it was a very interesting moment in time. And I don't even know the history of why that happened. But we back down from that because for women in particular, our body needs estrogen to do certain things. And when we start losing estrogen, we can get what we call the genitourinary syndrome of menopause. Now, here's something else I learned. Here's something. So y'all know I had the root canal gone bad. We had no idea for a year and a half. I had a bad infection in my mouth. We thought it was a sinus infection. They go in and repair it, right? And then because the infection was so bad, when they repaired it, it infected my tonsils and my vocal cords, which is why I've been gone for a month. So I'm going to the doctor for that. I'm walking to the doctor. The nurse takes my blood pressure. She goes, "Wow, your blood pressure's high. It's 150 over 100. She goes, "All right, let's take a couple minutes. Let's do it again." We take a couple minutes. I'm doing my deep breathing. I'm completely centered. Holy crap. It's 150 over 100. And she goes, "You know what? I want you back in 2 weeks so we can take your blood pressure again." And of course, I, being the person that I am with a bit of anxiety about illness, go right home and I start taking my blood pressure. For a week, it's 150 over 100, maybe 149 for 102, somewhere. That's high. That's really high. So I connect with my doctor and then I start reading about it. And I did not understand that there are two other things that happen with menopause. Number one, the loss of estrogen reduces the elasticity of your arteries and veins. Thus, your blood pressure gets a bit higher because it has to push the blood through these now stiffer veins. You know, I mean, we need to take a class in menopause. Wouldn't that be nice? Wouldn't it be nice if our mom had all that information and gave it to us in our 30s and 40s to prepare us? I had no idea that happened. The 30 to 50% of women who go through menopause end up with high blood pressure because of that. And here's the other thing. We become extremely salt sensitive. And that salt raises the blood pressure. Well, I was eating a massive amount of salt. I was eating salty popcorn every single day. I was putting salt on everything. You know why? Now, my blood pressure was 100. It is now, I took it this morning. Last night, it was a 123 over 79. I have reduced all salt. I am walking every day, miles. I probably walked 7 or 8 miles yesterday, to be quite honest. I have lost weight because there's nothing scarier than having a cardiovascular thing. And I think that I'm not going to have to go on any blood pressure medication. But anyway, just to bring this point home here, our body changes over time. And menopause changes a lot. It changes a lot, not only from our urinary tract, but also, for your heart. There's a greater risk of heart disease. And I had that little wake-up call, and except it was a scary wake-up call. And hopefully I can help you be a little bit more proactive about that too, right? So anyway, to get back to my point, millions of women have been told that they have a bladder disease, incurable bladder disease, when you do not have a bladder disease. You have estrogen atrophy. How are we going to treat it? Topical estrogen. But if you can't take topical estrogen for one reason or another, I was working with a patient who was in the grips of terminal cancer throughout her pelvis, throughout her body. And clearly they didn't want to risk that. That was well before she went into estrogen atrophy. So what can you do? Well, number one, another symptom of the loss of estrogen is dryness on the vulva. And again, men, I'm not ignoring you. Just let me get through this. That if you feel what we call urine burn, that your urine feels hot as you're peeing. If your urine feels hot as you're peeing, it's not hot, it's not burning you, it means your skin is dry. And that heat, again, urine burn is something that we strongly associate with estrogen atrophy. In fact, that's the only thing we associate it with. And so if you can't do the topical estrogen, what can you do? You can do a topical coconut oil, or you can do V-Magic, which is a wonderful olive oil, sea buckthorn oil that almost mimics mucus perfectly. Let me see. Do I have it here? Here it is. V-Magic. V-Magic is the bomb. Okay, because you have to remember that skin is meant to be wet. It is not meant to be dry. And so V-Magic, you can see it. It just looks kind of like Vaseline, but it doesn't have the consistency of Vaseline at all. It's a very, very slippery. It smells fine. I mean, it's just, this is something really good to use on your skin, okay? And then what do we do for the bladder? Well, for the bladder, because you've lost your estrogen and your bladder wall is thinner, then we have to do something that will coat the bladder. And of course, this is where Elmeron shined, right? Elmeron provided a protective coating to the bladder, but of course now we know that Elmeron is associated with pigmentary maculopathy, and it's pretty much off the table for the majority of patients that I've worked with. So what else can give you that coating effect? Well, you could potentially have a rescue installation. If you're in the middle of a flare and you're in a wicked, wicked flare, get yourself over to your urologist and ask for a rescue. They insert some heparin to coat your bladder, lidocaine to numb your bladder wall. That's one of the quickest ways to get yourself out of a bladder wall flare, right? Especially if you've already done our typical bladder wall rescue flare hour by hour rescue plans. If that's not working, you can always then go ask for that. Or you can look at the chondroitin-based supplements, because chondroitin is an active building block of the bladder wall. It's in the most inner part of the bladder wall in that mucosal layer. Research has shown that chondroitin is the most effective at restoring the superficial integrity of the bladder wall. And so you can look at those supplements as something that might be helpful, because we have no other therapies. There's no other traditional therapies that are going to replace Elmeron. There is nothing that has a bladder coating effect that I'm aware of that's in the pipeline for FDA approval. So really our only option is either the heparin installation, or it's going to be something like bladder rest or a bladder builder, right? Or cystomend or cystoprotect. So again, if we're try to protect that bladder wall and plump up that bladder wall, something like chondroitin is going to be helpful. Chondroitin, Gayla is saying, what's chondroitin? A lot of patients have taken glucosamine and chondroitin for arthritis. It's been around for years. It is found in our joints. It is just a very important molecule in the human body that helps joint integrity, skin integrity, urothelial integrity, et cetera, et cetera. And so a chondroitin-based supplement really is kind of the standard. So that's something that you can look at. Now let's go through some of your questions here. So hold on a sec. Okay. Jennifer says here, estradiol has helped the burning in my urethra, but you still have pain above my pubic area. You guess it's your bladder. I did test positive for gross hematuria, and the doctor says I need a cystoscopy. Jennifer, if you do have gross hematuria, then yes, they do need to look in your bladder to try to understand what's bleeding in there, because you might have a Hunner's lesion in there or something like that. You know, the AUA guidelines, they don't want to do invasive testing unless there's something that worries them. And anytime we see a lot of blood, normally we want to look inside that bladder to see if they can figure out what could be bleeding. And so I would support that, Jennifer. I think that having a quick cystoscopy, I mean, I call that a looky-loo, 5-minute test. They just numb your urethra, stick a cystoscope in, take a look around, pull it out, you're done. So I call it a looky-loo. And the only downside of having this cystoscopy is that your urethra is going to burn for a couple of days. Or at least 2 days. It's the first time you pee after having a cystoscopy is not fun. Am I right? I mean, you're like sitting on the toilet going, ow, 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 ow. Then you bite your lip and you just push it through to try to get through that first pain. That's what happens when you stretch the urethra. but letting them take a look. I mean, like, seriously, if I were my doctor right now and he said, I want to look in your bladder, I would let him. I've had two. I'm not worried about a cystoscopy at all. I'm a little bit more concerned about a hydrodistension with cystoscopy because that can traumatize the bladder more. That needs to be done in a very specific way, low pressure, short duration. Hello, Gabe from Texas. Hello, Nicole from Texas. Hey, man, we're having Texas Day. My mom was born in Bahia, Texas. I have family in Texas, several cities in Texas. Thank you, Lori. Nicole says, does recurring bladder infections, are recurring bladder infections connected to estrogen atrophy? Yes, absolutely they are. Because you've lost that nice thick coating that normally pushes bacteria away from those cells in your bladder wall. And so there is a group of women who do get recurring bladder infections. If you've had 2 infections in 6 months, 3 infections in a year, you are no longer a simple UTI patient. You are a complex UTI patient. And in the research that's been done with this, I attended a very good lecture on this several years ago by Dr. Anthony Schaefer. And what they did is they studied the urine, they did vaginal swabs, they checked everything they could for women getting recurring infections every single day. And what they found was about 24 hours before the bacteria arrived in the bladder, it was living very happily in the vagina. Which then had the researchers ask, well, wait a second, what's happened to the defenses of the vagina? Why has the vagina become a safe haven for bacteria? And the answer goes right back to estrogen atrophy. And so generally, if you're in this group, in addition to giving you antibiotics, they also give you topical estrogen to use vaginally to improve the defenses in your vagina. This is where you might find some benefit from using D-mannose. D-mannose is a simple sugar that the human body does not use. It has a receptor that matches an E. coli receptor. They meet in the bladder, attach to it so that the bacteria can no longer infect the bladder and you pee it out. But it's not as effective as something called a proanthocyanidin, a PAC. Proanthocyanidins are also a very good ingredient that is derived from cranberry that can help prevent E. coli infections. It's not acidic at all. And there's basically 2 on the market that are really, really good. One is called Illura, ELLURA. The challenge with Illura is that it is very expensive monthly, like a couple $100. Or you can do Prevent. And I have one. I don't have one of their new bottles. Prevent is also a wonderful product that is half the price of Allura, right? But the bottle doesn't look the same. They've taken away this dark thing, and it's more white with burgundy print on it. I just don't have a new one here in my office, right? So yes, 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 yes. All righty. Okay, hold on a second. Ellen Cretus said, wanted to ask you, why do my symptoms fluctuate so much in a month, especially before your periods? Because of your hormone levels. Your bladder, you know, your bladder is part of something called the urogenital sinus. So back when you and I were just a bundle of cells in our mom's uterus that just implanted, there was one cell that diversified to create the vulva, the vagina, the urethra, and the bladder. It's called the urogenital sinus. And that is why the bladder is so estrogen dependent. All right, Sam says, struggling this week. Why is it when I break up from work that week, regardless of diet, I'll be fine until I have a holiday from work? I always end up with an infection. It's like my body's waiting for me to rest, but I do rest when I get home from work. I don't do it. Well, okay, so when you go on holiday, are you traveling? Are you traveling? Are you taking a long plane flight? Are you taking a long train ride? Are you in the car for more than a couple of hours? We know that driving and traveling is a very common trigger for flares, but it's actually a pelvic floor flare. Remember, the bladder only knows one language: frequency, urgency, pressure, pain. It only has two nerves that can tell you there's a problem: the alpha afferent nerve, which gives you frequency, urgency, and the C fiber, which gives you pain. So every injury to the bladder will feel like a UTI. Everything feels like a UTI. A bullet wound to your bladder would feel like a UTI. A stab wound would feel like a UTI. An injury like chemotherapy will feel like a UTI. Everything feels like a UTI. And for many of us, we all thought we were having UTIs over and over and over again, only to find out that our urine was negative. And in fact, we had maybe a chemical injury to the bladder, like from drinking too much coffee or soda, or we might have a physical injury to our pelvic floor from driving, et cetera, that could easily trigger that issue. So Sam, I bet it's the traveling that's doing it. Hi, Erin. Becky says, I'm here. You're 3 weeks postpartum and your IC, oh, honey. And she says her IC is bad. Is it your pelvic floor, hun? Your pelvic floor took a beating. Angie says, nice to see you back. Thank you, Angie. Lisa says, okay, so Lisa had the breast cancer and can't take estrogen. Again, Lisa, you need to Google it, because we have, especially in the last 5 years, a number of research studies which now very clearly say that topical estrogen does not add a significant risk. Betsa said, the side of my thighs have been feeling achy and tight. How do you know if it is arthritis or part of pelvic floor dysfunction? Yes, I have SI joint issues. The doctor prescribed you estriol cream. Well, I mean, your thigh muscles go right up into your pelvic cavity, your hamstrings and your thighs. And so if your muscles in your lower back, if your muscles in your pelvis are tight, the odds are they're going to reflexively cause some tension in your thighs as well. Sometimes I get tension in my thighs if I've been sitting too long. So I think ultimately in the end, it's about going to a physical therapist, having her touch your muscles and see if she can reproduce the pain. Arthritis is arthritis. I have arthritis in my right jaw. That's one of the things we found out in the last month. That's why my TMJ has been so bad. I've got arthritis right here. So annoying. Angie said, oh my God, my blood pressure Friday at the ENT was 143/99. Angie, I'm telling you, girl, I was eating a ton of salt. And my stress level has been very high. I have become Zen in the last 3 weeks since you've seen me. I get out, I walk, I get off of my iPad. I do not start the day with the news. I stop all conversations at home related to anything to politics. It's like, I do not want to hear it. Stop. I am making, and now I get to say, I'm trying to reduce my blood pressure. I do not want to engage in a political conversation with you right now. Rebecca says, what's more effective, a topical or vaginal estrogen? Well, the topical estrogens are used vaginally, so they're kind of the same thing. I think maybe your question is, what's the difference between a cream versus a tablet? Like Vagifem? Vagifem is a little tablet that you can insert vaginally to also deliver that estrogen. They also have a ring that you can put up there. But the challenge with the tablet and the ring is that it doesn't give you the flexibility to put some of the estrogen on your vulva and maybe at the entrance to your urethra if your urethra is tender. One of the other things that happen, yeah, you guys, I have no freaking shame. I will pretty much talk about anything and embarrass myself. If I can embarrass myself and help you understand things, I'm going to do it. So you know that we women, we have an inner labia and we have an outer labia. We have inner lips, which basically cover the vagina and the urethra. And then we've got our bigger outer lips, which cover everything. When you lose estrogen, what happens is your inner lips resorb. They just say they kind of go away. Mine are gone, which is very weird. And I talked to my doctor about that, because that's what happens. So if I had used my topical estrogen a little bit earlier and used it maybe on the labia, I might have prevented some of that. And I think they can improve with that topical estrogen too. Debbie said, I have low pressure. I always had my doctor approved estrogen cream from the Women's International place that you suggested. It's expensive for you, $75 to try. That's where I get mine. That's where I get mine. And it was my OBGYN who recommended them because they specialize in estrogen for people who are super, super sensitive. Erin says, how often do you suggest applying estrogen on the vulva? Well, it depends. I can't give you that. I cannot give you a medical recommendation like that. What I can tell you is that it depends upon how dry your skin is. For women whose skin is really, really dry, they might have you do it daily for like 2 or 3 weeks, and then you go back down to 3 times a week or 2 times a week. But the proof is in the pudding. What does your skin look like down there? If your skin is not responding well, they might have you increase it. If your skin looks good, they might have you back off a little bit. Afton said, is it common to have burning in the urethra and bladder after urine with estrogen atrophy? Absolutely. Absolutely. Also, it is almost always right before menstruation, the week before. Yep. That is very, very common. Feels like there's a drop of urine stuck in your urethra that won't come out. That's what it felt. That's what it felt like to me. It hit me when I was 52, and I'm now 10 years older than that. I just turned 6. You guys, I didn't get to do a birthday stream. I wanted to do a birthday stream 2 weeks ago. I didn't get to celebrate any birthday this year, except for yesterday when my best friend came over because of COVID. So yes, I am now 62 years old. Dang, I don't know how that happened. And I feel 25. It makes no sense to me. It makes no sense to me. Jessica said, my urologist recommends this to prevent recurring UTI. Is it worth it? The product is Eucora. The challenge with Eucora is that it's a bit more acidic. I don't have good success stories with Eucora. I have excellent success stories with Prevent and with Allura. You're always welcome to try any of them. I mean, Eucora, they have fancy ads, so a lot of people know about them. It's a packet of powder that you dissolve in water and drink, but it does appear to be a bit more on the acidic side, regardless of what they say. I have had patients call me who've had problems with Eucora, whereas Prevent or Allura definitely doing exactly what we want it to do. It's a very strong proanthocyanidin product. Prasid says, hi, Jill. How are you? Guess what I'm doing? 3 hours of pelvic muscle therapy every day, and I find a lot of improvement. Yeah, woo! 3 hours is a lot. I'm impressed. Initially, I felt a lot of flares while doing the exercises, but now it's settling. Excellent. Excellent. The more you work with your muscles, better. 3 hours a day. That's kind of a lot. I mean, I'd be happy with an hour, to be quite honest. But you do you. Deidre, it still takes Elmeron. Okay, so Deidre, you absolutely should have your eyes checked. Your retina, it's not a basic eye exam, it's a retinal exam. So a different eye doctor does it, a retinal specialist, to make sure that you're not showing any signs of this retinal disease that Elmeron has now been associated with, called pigmentary maculopathy. And the reason why we want to be on top of that is because it has been progressive in some patients, and some patients have approached and are legally blind now because of it. So we want to really take that pretty seriously. Lisa, thank you so much for the 99 stars. So much appreciate it. Erin says it's like ground glass or charred glass. Erin, when you use the, wait. Hold on. Erin, are you saying that your vulva feels like charred glass when you put it on there? Not surprising. Again, that heat is coming from dry skin. And so a lot of women, when they start estrogen for the first time, it scares them because the first time they use it, it gets really hot and you're like, oh my God, it's burning me. I don't want to do this again. Well, you have to understand that the worst thing you could do is stop it, because your skin is just going to get drier as you get older. We have to power through that first week or two. Every time you use that estrogen, the heat gets less and less and less. And it took like a week and a half for it to go away for me. So the first time I used topical estrogen, it was a strong burning for like 15 minutes. A week and a half later, it was like a little warm puff of air, like poof, and it was gone. If I don't use my estrogen for a week or two, because I have been known to do that, then the heat comes right back because my skin gets drier again. Okay. Gayla says, my doctor diagnosed you with two, I think the typo demon got you there. Two batteries. So you got Proteus, Mirabilis, and Actinomycin, and you're on Levaquin. Those are two definitely challenging infections, hon. I'm glad that they have found it and that they are treating it. Oh, there you go. Eileen says, I use Allura daily, but just saw they are manufacturing an alternative to estrogen. Just a suggestion. I use Uvafem, which is slow time release estrogen that you insert vaginally. That's a great idea. You know, the challenge, though, Eileen, is, and I say this almost every day because I have this conversation literally every single day in my office with somebody new, is you'll never have a 20-year-old bladder again, even if you're using estrogen. We now have a bladder that is compromised. And so having a little bit of an extra coating in there, like from the chondroitin supplements like Bladder Rest, to having a little extra that might help keep some of that bacteria away for those who struggle with recurring UTI is not a bad idea. There's this kind of perception that, well, my bladder's normal now, right? And it's like, no, Jill, you have a 62-year-old bladder that is being helped by estrogen, but it is 62 years old. It is not 20. And we all have to, find that balance with food and with everything else as things start to change as we get older. Eileen says, Allura, you take one pill a day, 114 for a 3-month supply. That's a little lower than the last quote I got. That's good. The Prevent is like $60. And Prevent has more of the critical ingredients in Allura, if I remember correctly. So I think you get more bang for your buck with Prevent than you do with Allura. Vicky says, hold on a sec. Scheduled installations are the best way to heal from Hunner's lesions. I've had 3. No. Bladder installations are not considered a therapy for Hunner's lesions, hon. Hunner's lesions therapy is cauterization or laser therapy, or fulguration. They all use heat to kind of kill the lesion, or a steroid injection, or hyperbaric oxygen therapy. Those are the 3 most common treatments. There's no other treatment that we have right now that has shown a beneficial effect. If you look at the new AUA guidelines, they have, so remember the old guidelines from 2014 had 6 steps of treatment. You started at step 1, you do everything in step 1 before you go to step 2. You do everything in step 2 before you go to step 3. And they wanted you to understand the risk of adverse event. They didn't want you to go to step 5 until you've done step 1 and step 2, right? We were trying to minimize the risk of trauma to your body. Well, unfortunately, they decided to stop using the 6 steps to give doctors more flexibility. And one of the points that they make is if they suspect that you have Hunner's lesions, they want that hydrodistension done immediately, and they want those lesions treated immediately. And the research for the treatment of Hunner's lesions is incredibly good, like anywhere from 80, 85, 90, 90%, 90, 95% of patients with Hunner's lesions who have them treated correctly respond well. But there's no bladder installation that's going to treat a lesion. And anybody who tells you that, I think is being very misleading. Like DMSO, it makes no sense. And the AUA guidelines specifically say that the only way to treat a lesion is with heat therapy or with a steroid injection, because that's what the research shows. So I would hate for you to spend a couple of years doing bladder installations thinking they're going to fix your lesions, because they're not. Anne says, how do you stop underwear leaks? Well, I mean, we have to know why you're leaking. Are you leaking because you are in total estrogen atrophy and your muscles have gotten weaker? Or are you leaking because you've got really severe pelvic floor dysfunction? That's a little tricky. I will tell you, I am now absolutely at that point where if I have to sneeze, I do a Kegel. If I have to cough, I do a Kegel. Because if I don't, every now and then, like I've never wet my pants, but sometimes I think I'm going to, you know. Karen says, my insurance won't pay for Elmeron, and now I'm in a flare for 4 years. So Karen, we have an Elmeron transition guide right on our website, but the supplement that, so again, you got two options. You can go to an Elmeron installation where they put 100% of the medication directly in your bladder. I mean, the fundamental flaw with Elmeron is that you're swallowing it. And this is called bioavailability. How much of the medication arrives in the bladder to give you a beneficial effect when you swallow it? Elmeron is terrible, that literally over 90% of it is destroyed by digestion. And I think the company, Baker Norton study, the company that originally had it, showed that 92, 93% of Elmeron was destroyed by digestion or rendered ineffective. And then I was talking with a doctor last year or the year before who said, well, we think it's 3 to 5% of the Elmeron might arrive in the bladder. And unfortunately, then you have to take a lot of it over time to get a significant amount in there to be beneficial. Well, the absolute better way to use Elmeron is to just stick it right in the bladder and not swallow it at all. That way, 100% of the medication arrives in the bladder, where it stays in the bladder, and we do not believe that there's any, that there's associated risk of retinal disease when you use the Elmeron as an installation. And of course, Elmeron and heparin are interchangeable. So you could do an Elmeron lidocaine installation. You could do a heparin lidocaine installation. So that would be the one way you could continue to use the Elmeron. Or you can transition over to a chondroitin-based supplement. And the supplement which is going to be the closest to providing a really, really strong, thick bladder coating effect is Cystomend. And I don't have a bottle of it here that I can show you, but it's in our shop, Cystomend. Or you can, if you're struggling with pain, you can do the bladder builder, which also has the PEA in it for pain relief. This is also, bladder builder is, in my opinion, the best supplement on the market today. It's the most dynamic supplement on the market today because it has the most methods of action. It has many different ways that it can help. It's got chondroitin for the bladder wall. It's got quercetin for an antihistaminic effect. It's got beneficial probiotics for the biome for your bowel. But most importantly, it has PEA in it, palmitoyl ethanolamide, which has been proven in research to reduce IC pain. So if you need a bladder coating effect with a pain reducing effect, that would be bladder builder. But if you flare when you eat a probiotic, we would say pass on this because this has probiotics in it. And some patients do have a histamine reaction to probiotics. If that's the case, then you would probably be doing bladder rest and Piora, those two together. would be potentially helpful. Jennifer says, have you heard of any link to parasites in IC? I might have a parasite apparently for who knows how long. You know, hon, it comes up every now and then. We just don't have any data that's linked it as being a substantial problem. I mean, I would consider Lyme disease a parasite. And we've certainly found that in the bladder. We have certainly found the Epstein-Barr virus in the bladder. But if you're thinking worms or stuff like that, no. If the parasites generally are going to be bowel associated. I had a bowel worm when I was in high school and went to Hawaii to visit family, and my cousins had me on Kauai go off the slippery slide, which was a concrete slide built into a waterfall, and the water was brown and green. I swallowed the water, got a worm. You want to talk embarrassing for a teenager, leaving a stool sample at 18 years of age because you have a freaking worm in your bowel. Nicole says, I'm 42. Is this too young for estrogen atrophy? No, not at all. Especially if you've been, have you had a hysterectomy? Everybody's different. For some people, they start perimenopause in their late 30s or 40s. You're in your early 40s. You're definitely entering perimenopause where your estrogen levels are going to be dropping. Proceed said, can dry eyes be associated with Elmeron? Not that I know of. With the Elmeron, with the pigmentary maculopathy, like the number one symptom is difficulty having your eyes adjust when you go from dark to light or light to dark. You might have blurry vision. You might have lines in your vision, blind spots, things like that. I haven't heard of dry eyes associated with that. Thank you for the birthday wishes, you guys. Deidre says, where can I purchase Prevent? Over in the IC Network shop. Just go to icnetwork.org and you can go on over to our shop, which is actually on a different website, icnsales.com. Tanya said, I had to go back on estrogen cream at 70. My vulva was burning more so than my vagina. Crazy. What about using Replens on non-estrogen days? Well, Replens is not oily enough. You have to remember that the mucosal barrier is what we call hydrophobic. It's not water loving. It pushes water away like oil does. And so I don't see Replens providing, it might help ease for 5 or 10 minutes a dryness sensation, but it's not going to stick around to be that helpful. Something like coconut oil, which is has a natural antibacterial and antifungal effect. That's what I've used. I've used coconut oil, and I have used V-Magic, again, the V-Magic. Medicine Mama's V-Magic is wonderful. You can get this in the ICN shop. We have coconut oil too. Elizabeth says, I just had a pelvic exam and my entire pelvis started hurting. I contacted that doctor afterwards. He asked if I had IC and he said, that's why. Why does it hurt so bad after pelvic exams? He said I needed pelvic floor physical therapy. Well, honey, but you've already had that. Yeah, but Elizabeth, pelvic floor physical therapy is not a one and done. That if you have tight muscles, here's the problem is the pelvic floor muscles, specifically the levator ani muscles, are the only major muscle group in the human body that control bodily functions. The health of the muscle is going to determine if you're going to urinate normally, if you're going to have bowel movements normally, and if you're going to be able to enjoy sex normally. So if your pelvic floor muscles are tight, it's going to be hard to pee. That's why one of the classic symptoms of pelvic floor tension is that you sit on the toilet or stand in front of the toilet, and it takes 5, 10, 15, 20 seconds before you can relax enough to release urine. So when your muscles are locked down tight, it's hard to let stuff out, whether it's urine or whether it's a bowel movement. But it's also hard to let stuff go in. That's why sex is painful. We call that, for some women, vaginismus. Their muscles were badly tightened from an injury in childhood, and they've never had pain-free sex. It's always been painful because our muscles are locked down tight. And so what we want to do is get back to that pelvic floor physical therapy and see where your muscles are. There are a group of patients who, the thing with pelvic floor physical therapy is that for some people, it's a short-term injury or trauma. Let's just say that you fell, but you don't have a permanent injury. But let's just say you fell a couple of times and your pelvic floor muscles have gotten tight. So we can normally expect that with a couple of physical therapy sessions and you doing some stretching at home and maybe some internal work at home, that should pass. But there's also a group of patients whose muscles, no matter what you do, they stay tight. They stay really, really tight. And this was the mystery that Dr. Jerome Weiss solved. Jerome Weiss was a urologist who back in the 80s saw very early on bladder therapies didn't work for the vast majority of IC patients. And so he started looking beyond the bladder. And he broke the mold for a urologist because he said, well, clearly, if bladder therapies aren't working, this is not a bladder issue. Let's look and see what else is happening in the pelvis that can cause this. And he became an expert in muscles and ligaments and tendons to try to understand how those would influence us. And so, he eventually became a master. He was probably the best urologist on the planet doing pelvic floor physical therapy. But what baffled him were the group of patients who a week later, 2 weeks later, a month later, 2 months later, called him back and said, it's back. And they would come back into the office and the exact same muscle is now tight again. And the exact same trigger point has reappeared in the exact same spot in the muscle. And he found that very intriguing and very baffling. Why? And that's when he started looking at bones. Because what puts long-term pressure on muscles but bones? So do you have a bad hip? Do you have a bad SI joint? That makes sense. I have a bad SI joint on the left side. It's an old athletic injury. And so my left side piriformis muscles are always tight to one degree or another. Right? And so that's something that I have to work on. And it makes sense if you have a bad knee, that could play a role, because if you have a bad knee, the odds are you're limping. And if you're limping, your hips are no longer level. Your hips are now like this. And that's putting weird pressure on your pelvic floor. But here's what he found. And the same is true if you have one leg longer than the other. If you have one leg longer, even by 1/4 of an inch or 1/2 an inch, your hips are no longer level. And as you walk, think about what that slight imbalance is doing over time. But he solved the mystery when he started working with a foot researcher, a podiatrist. And what they found is 90% of the patients who had long-term chronic muscle tension had a foot problem. They were not walking normally. If you have a history of plantar fasciitis, Morton's neuroma, Morton's toe, shin splints, then that tells us that there is something wrong with the way that you are walking. And so he ended up referring those patients back to a podiatrist to get them to look at how you were walking. And the book is all right, where's the book? Oh, here it is. Here it is. My doctor would not be happy that I'm doing this meeting today. He wanted me off on voice rest for a full month. But anyway, I'm 3 weeks. This is the book. This is the book. This is the book. In addition to our IC 101, which is an excellent book, which helps you. Our book is IC 101. It's not just a bladder disease. Great place for newly diagnosed patients to start. But if you have any history of muscle trauma, any history of long-term muscle tension, if you were an athlete, this is the book. And his chapter on the feet is insane. It's so good. It will blow your mind. And I want you to think about this. Let's just look at this picture here for a moment. Okay, let's look at this picture for a moment. So this picture shows what happens if you have an ankle that's rolling in. So let's look at the normal foot first. So here's a normal foot on the ground, and you'll see that the shin is basically going at a 90-degree angle straight up from the foot. And then the femur is still, we're still looking at a straight upward. And you can see there's your, one of your pelvic floor muscles right there. That's your piriformis muscle. That looks good. Now let's go over onto this side. Look at how this piriformis muscle is almost twice the length of the other one. Why? Because look at this. If you have an ankle that rolls inward, now your shin is not straight. It's pushing out to the side, right? And now look at the femur. The femur is continuing this abnormal curve away from center. And you can see what that does to the pelvic floor. So if we can stabilize this ankle so that it's not rolling in, that's going to make a world of good. Oh, and by the way, you guys, I have a freebie for you. Hold on, let me go get them. Hold on. Well, where is it? Did I put it? Oh, here they are. Here they are. I forgot. So, right when I went on voice rest, we had just gotten our summer magazine. And I've got about 10 copies of our magazine to give away for free for anybody who would like it. So here is the IC Optimist. And this is a special double issue where we go over the new IC guidelines, a hydrodistension survival guide for people who are going through hydrodistensions, things for young mothers who are struggling to be a mom with their young children, pelvic pain car buying tips. Anyway, we go over the AUA guidelines. We go over the EAU guidelines. We've got a great article on bladder-friendly Mexican cuisine. Let's see. I wrote this article, pelvic pain car buying tips. Vitamin D. That if you are low in vitamin D, that absolutely can increase your pain levels. The latest research, all sorts of stuff. The new EAU guidelines in the European Association of Urology, they will no longer be using the term interstitial cystitis at all. It is going to be a bladder pain syndrome or pelvic pain syndrome. So if anybody wants a free copy of this, I just need you to email me your snail mail address, and I will send them out tomorrow. So my email address is super easy. It's icnetwork@mac.com. That's short for Macintosh Computer. So the letter I, well, just right there, icnetwork@mac, M as in Mary, A as in Apple, C as in Charlie.com. Email me your mailing address and I will snail mail one to you. Or if you don't want one emailed, I will email you a copy of it. Because I want to get this word out because these new guidelines are really, really, really important. Okay. So again, if you want our latest summer magazine, just email me, icnetwork@mac.com. I will get you a copy of it, no charge. And of course, on the back, this is the cover for our book, IC 101. We had a great review from a doctor who said, God, I wish I'd had this book 20 years ago. She said, Jill, you have no idea the number of lives you would have helped if we'd had this book 20 years ago. Well, we're trying. We're getting there. Hello, Kayleen, girl, how are you? Okay, hold on. I gotta. Judy said, such great information you're giving to everyone. Going to pass this on to your daughters. Excellent. Happy to help. Thank you. Thank you, hon. Marcia said, after having a bladder infection all of July, since you had the test July 7th, but not informed until July 26th, it was caused by a medical instrument used in an endometrial biopsy. Test showed Enterococcus facialis. You know, I honestly don't know how to pronounce that. Is it facialis? Facialis? On 5 days of macrobid since July 26th, just finished, but you still have severe bladder pain, you need to repeat the macrobid. Actually, listen, if the macrobid didn't touch it in 5 days, then you probably are going to need to switch to a different antibiotic. Hopefully, they've done antibiotic sensitivity testing, Marcia, to give you a very clear idea of what the correct antibiotic would be to treat that. Okay. I mean, if you've done macrobid and it just hasn't, if it didn't even take the edge off, then you're going to have a discussion with your doctor about what would be another antibiotic that would be useful. Now, I will tell you that with my my drama of having this infected tooth for 1.5 years that gave me the infected tonsils and vocal cords, they wanted me on clindamycin, and I refused because clindamycin has a risk of a very severe photosensitivity reaction that could last 20 years, where you can't go out in the sun. And I live in the sun. I'm like, no, I'm not going to do that. Then they wanted me to take Augmentin, and I went, no, that's going to irritate my bladder. I'm not going to do that. And we went to amoxicillin again. Oh, 2 months after we did it before. But the swabs keep coming back normal. That's the thing. It's just normal. They're not, even though my tonsils had white spots on them and were red, and we did many swabs, that they weren't identifying any unusual pathogen, which was, you know, annoying as hell. Elizabeth says, I have trouble starting a urine stream. I've already had pelvic floor physical therapy. I think there's something neurological going on in the signaling between my brain and my bladder. I had hydrodistensions, and I think that's what caused it. Well, but there's no such thing as you had pelvic floor physical therapy, Elizabeth. You have to continue pelvic floor physical therapy. Would a hydrodistension damage your nerves and make it difficult for you to urinate? I don't think so. I mean, unless it was done 10, 15, 20 years ago where they massively overstretched your bladder, I don't really see a case for that happening. It's possible. I mean, I totally believe you. But I also think that your pelvic floor muscles could still be tight or could have gotten tight again. Lisa, is there a way I can talk to you privately? Absolutely, hun. We have you can see my phone number right there. It's 800-928-7496. 800-928-7496. I work with patients every day. I will tell you that this is a busy week, though. Let me look at my week here real quick. Hold on. Tuesday. Boy, I see all your emails. Great. Excellent, you guys. Keep the emails coming. Hold on. Let me just look at my week here real quick. Actually, it's not as, wait, I'm looking at July. Come on, Jill, go to August. Okay. So, I'll be up late doing a presentation for the Global IC Society big meeting. And so we're starting that at 9 p.m. Tuesday night. And that'll go on for a couple of hours. So I don't, Tuesday might be challenging because I have to prepare for that. Wednesday's wide open. Thursday afternoon after 2 o'clock, 2:30 is wide open. Friday is wide open. Okay. So yeah, you guys, I mean, literally people are stunned that I answer the phone. I do not have a secretary. I answer the phone. If you get our service, if you call the 800 number, if you go to the patient support phone line. And if I don't answer it, or my staff doesn't answer that, that means we're already working with somebody. So leave a message and I will absolutely call you back when I can. I'm also known for calling back late because I'm in California. So if you call on the East Coast and I'm still working at 5:30, I might call you at 8:30. So check your, have your phone with you. All right, hold on a sec. Yeah, so Lisa, just give us a phone call. And for anybody who wants to spend a lot of time, like you want to talk for like an hour, you can sign up for coaching too. Gayla says, is drinking more water a day to decrease the burning? Okay, is drinking more water a way to decrease burning pain? And no. When you drink more water, it will dilute your urine, which will then dilute the irritants in your urine, which is causing the burning. So if you're having a bladder wall flare from drinking, let's say, a cup of coffee or some orange juice, both of which are going to hurt, normally what you would do in your rescue plan is as soon as you have any pain or discomfort is drink a big glass of water so that we can immediately dilute those irritants out of your urine. Then the second thing you can do in that first hour is alkalinize your urine with a Tums or a Pre-Leaf. Pre-Leaf is the bomb when it comes to trying to reduce acid in your urine, right? So Pre-Leaf is definitely a viable option. And they are coming back with their powder soon. Kayleen says, I feel too young to have incontinence. I think it's even gotten worse since after surgery. I'm going through 2 liners a day. Hun, girl, you are the epitome of pelvic trauma. You are the epitome of someone who has faced severe trauma and long-term trauma to your pelvic floor. So it doesn't surprise me at all that you're struggling with some incontinence right now. But that pelvic floor physical therapy should help that tremendously. So I think for the short term, it doesn't surprise me. Now, got to start working with that pelvic floor physical therapist and really understand what's going on with those muscles a little bit more. Vicky says, do you see any connection between oxalates and Hunner's lesions? Well, oxalates are not going to cause a lesion, but oxalates will irritate a lesion. Foods that are high in oxalates, you guys, oxalates are crystals that come in foods like chocolate, berries, spinach. And oxalates are also associated with the development of kidney stones. You can have oxalate stones. And unfortunately, oxalate crystals are sharp and irritating. And so it was the Vulvar Pain Foundation who made that connection between foods high in oxalates irritating the vulva 25 years ago. See, my throat's starting to get a little funky here. And so we certainly know that some patients are going to be more sensitive to oxalates. And so reducing those oxalates is important, but I don't see oxalates causing a lesion. Gayla says, you've got so many questions. Honey, it's okay, hon. That's why we're here. But you say there's hope with estradiol cream? Absolutely. You have it, but you haven't started it. You were also diagnosed with atrophic vaginitis. Exactly. You have atrophic vaginitis, which is exactly why the estrogen was given to you. So the skin, the skin in your vagina has become atrophic, which means that you're basically in estrogen atrophy. The skin has weakened and gotten thicker. So that topical estrogen is the one thing, the single most important thing for you to use, because that skin will immediately absorb that estrogen and start producing that mucus. That skin will plump up. It will get thicker. It will get more robust. It will get stronger. And they've watched this happen in labs. I mean, topical estrogen is remarkably helpful in improving the health of the skin. Now, be prepared for the fact, Gayla, that when you use it the first couple of times, it's probably going to feel very hot. And you're going to go, oh, no, 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 I don't want to use this. But you have to power through that. Because if you don't use it, you're just going to get progressively drier and drier. And then you're going to wait 5 years. And believe me, 5 years later, it's going to hurt even more. You kind of have to work through the first week or two of that heat so that that skin finally has enough estrogen to start producing a bit more mucus. Gayla says drinking water makes symptoms worse. It can. I mean, if you're drinking too much water, you're giving yourself mini hydrodistensions, and that's not good either. Marcia, so your doctor said macrobid was appropriate, but was it effective? If you're still having symptoms, it wasn't effective. Oh no, Laura, are you kidding me? So Laura said the same exact thing happened to me. She's talking about somebody who had the infection all of July. They then put you on Cipro, and that you believe that it caused you some permanent nerve damage, but more importantly, you had a sensitivity test, and it found you had the resistant gene to Cipro. So Cipro is off. So it's good that we know that, and it's good that Cipro is off the table for you. But Cipro, we had FDA warnings on Cipro years ago because the risks outweigh the benefits. Cipro is not for simple UTI. It is only for complex UTI. And that's only if everything else has been tried. So I'm so sorry that it gave you some nerve damage. That's one of the risks. Cipro is also associated with aortic aneurysm. We have a very prominent IC, or very, very important woman in the IC world who has an aortic aneurysm from Cipro. Elizabeth says, have I heard of the cramp study? It's based on the theory that severe menstrual cramps increase pelvic disorders. I've always had painful periods. Brief study. The purpose of the study is to determine if some women with painful periods, here, hold on a sec, are future risk of developing chronic pelvic pain, and if oral contraceptives can be used to reverse the pain risk. Interesting. You know, I have a memory of somebody mentioning, or I read about it somewhere, but it's not something that I've really looked into. I think it's going to be interesting to see what they find. Kayleen says, I'm awesome other than the damn incontinence. Oh, sorry for swearing, but it is what it is. PT said, I'm ready for the wand and dilators. Excellent. I was hesitant until I dug out a boyfriend. Now I have a reason for pain-free sex. Yes. We're not ready yet, but I don't think there's a problem to start healing. Oh, I'm so happy, honey. I'm so happy. Sherry says, I feel so defeated with this pudendal nerve pain. Oh, Sherry, honey, big giant hug. Big giant hug to you. I know. I know. You know, so you guys, pudendal nerve pain comes from patients who have muscles so tight that it's squeezing the pudendal nerve. And one of the classic symptoms of pudendal nerve entrapment is pain when you sit down that gets better when you stand up, or pain that gets worse when you bend over or you move your body into a certain position. And when you change that position, it goes away. But one of the most persistent symptoms of pudendal nerve pain is PGAD, persistent genital arousal disorder, where you feel this painful arousal sensation. And you're like, what the hell is this? I don't like this at all. And I call it one of the dirty secrets of IC, because we don't tell anybody about it, because you don't want anybody to think you're getting some sort of rush after having pain. And so it's a dirty secret in the sense that people incorrectly perceive it as a dirty secret. It's actually really common. And the explanation is really simple. It just means you have a muscle that's that tight that it's squeezing this nerve. So, and sometimes it can be related to a birth defect, that the nerve is traveling a different way across a bone that can cause that nerve compression to happen. And there are other potential triggers too. Sherry, are you so have you done the nerve blocks yet, Sherry? Did they do a nerve block? Tia, severe flank pain related to severe IC flare? If it's related to muscles, yes. That low back pain often comes from the psoas muscles, and the psoas muscle is like a big, thick rope down both sides of your spinal cord. I mean, it's like this much in diameter. It's a big, meaty, thick rope that goes right down both sides of the spine and goes right down into your pelvic cavity. And when that gets tight, that can cause that low back pain, and it can be severe. I've had that several times. Marcia says the sensitivity for the bacteria was only macrobid. Well, I would look at it a different way, hon. I mean, was it next gen testing? Did they do a next generation test to make that decision? Or was this based upon antibiotic sensitivity testing? Sherry wants to know if anybody else here has pudendal nerve entrapment and how is it treated? So generally, Sherry, it's treated in a couple of different ways. It's treated with medication to calm the nerve, from a lidocaine cream that you can use on the skin to something like gabapentin, Neurontin, or even amitriptyline, Elavil. So our goal here is to calm the nerve collectively, but we also need to try to figure out where the nerve is compromised and deal with that muscle or structure that's compromising it. And that's where this book is so important, because this is the master class in all things related to this. And let me just see, Sherry, if I can find, hold on a sec. Okay, here, let me read you this. Okay, let me read you Jennifer's story from this book. This is in his section on PGAD and pudendal neuralgia. Jennifer is a 61-year-old woman who, about a year prior to her first appointment with me, had developed urinary urgency, frequency, and pain, and had been told she might have IC. Her physician had treated her with antibiotics, though her urine cultures were negative. About 3 months after the onset of her symptoms, she began to experience vulvar burning, which alternated with burning around the urethra. Then she began to have burning on the right side of her sit bone, accompanied by difficult bowel movements that required straining. Next, her urinary symptoms progressed to include hesitancy, interruption of flow, and the sensation of the urethra being squeezed. She also developed difficulty with penetration during intercourse and pain when she spread her legs apart, which took a toll on her work as a dance instructor. While taking Jennifer's history, I learned that 14 years prior to her appointment with me, she had suffered a bone spur in her right hip socket. And when I examined her, I found skin sensitivity around the right sit bone and perineum, as well as sensitivity around the vulvar vestibule, especially in the area near the urethral opening. Internally, I noted marked tension of the pelvic floor muscles with trigger points in the urinary sphincter and right obturator internus, which is the hip rotator, as well as an exquisitely tender right pudendal nerve. I also noticed severe bilateral Morton's toes, indicating the likely presence of biomechanical compensatory dysfunction that no doubt contributed to the development of her problems. I can talk about that separately. It was my initial thought that abnormal biomechanics in the hip rotator trigger points could have produced the pudendal nerve sensitivity, as well as the urethral, urinary, and vulvar symptoms. Therefore, I initiated a treatment regimen of internal myofascial release and nerve mobilization therapy, supplemented with regular physical therapy sessions and foot pads to correct her Morton's toe. I also injected stubborn trigger points in the right obturator attachment at the hip. Though Jennifer made steady progress on this program, she nonetheless experienced periodic relapses. After approximately 8 months, I concluded that the nerve required a more aggressive approach, and I administered bilateral nerve blocks. Following this treatment, Jennifer proclaimed, "I feel so wonderful." Now there was no further pudendal nerve sensitivity. Only a few tender trigger points in the urinary sphincter muscle remained, and these resolved with continued myofascial release and acupuncture. At the time of her last appointment, 18 months after her therapy began, Jennifer thanked me for a really good year and asked how the book was progressing. I told her it was almost there and mentioned that I was holding it up to add some interesting material on PGAD, which had only recently become a bona fide medical problem. To my amazement, she then confessed that about 6 months after her sessions with me began, she had experienced clitoral arousal during my treatment of the muscles associated with pudendal neuralgia. While this concerned her at the time, she'd been too embarrassed to mention it. See, dirty secret. The arousal experience had recurred over a period of several months and then resolved along with her other symptoms. In effect, my work on the trigger points in these muscles had created the primary problem with PGAD, which confirmed the muscles as the cause of the problem. And this is called rebound sensitivity. Okay, well, anyway. And then we have Leslie's story. This book, guys, best book ever written. I mean, listen, I rewrote and wrote a good portion of IC 101. And I do think before we know your muscles are part of the problem, IC 101 is the book to start with. But once we have a clue that your muscles are a problem, this is your Bible. And it is so encouraging because there are so many success stories in it. But it's like, you're going back to school. The first 4 chapters, you're going to be in school again. You got to take notes. You got to understand where things are. I need you to be able to be laying on your back at the physical therapist, visualizing which muscle they are touching. Is it on the left side? Is it on the right side? Is it shallow, like levator ani? Is it deep, like the piriformis? Your best chance of success is you knowing what they're doing. You can't just close your eyes and say, do it. I don't care what you do, just do it. You can't do that. You cannot do that. You have to know. So you have to study. And this book will change your life. It is a phenomenal book. What are my thoughts about pain pills for IC flares? I got no problem with pain pills for IC flares. Pain medication in the AUA guidelines is not considered a treatment for IC, but they absolutely encourage you to use pain medicine and a variety of multimodal therapies to get through flares. But we have to understand the type of flare you're having, right? So if you're having a bladder wall flare, then we have a rescue plan for that. Number 1, dilute your urine with water. Number 2, alkalinize your urine. Number 3, you can numb your bladder wall with azo. And if none of those work, then pain med might be on the table. I use Norco. I have used Norco over the years quite successfully. Never used a lot of it. Never even taken a whole pill. Even after my hysterectomy, I never took a whole pill. I always took at most a half a pill. So, but in the end, you can't just rely on pain meds. And some of you have done that because I've had conversations with you and you are just like, pain meds. And it's like, no. What you need is to understand what's causing the pain in the first place. Because if we can fix what's causing the pain, you won't need the pain meds. But I understand the desperation. I understand the agony of being up all night crying, begging for somebody to help, because I lived that life for years. I totally understand that. But whenever you interact with your doctors about pain, you got to have a laser focus on, doctor, can you please help me? What's driving this pain? I need to understand what's driving this pain, because I want to freaking treat that. I don't just want to take pain meds. I want to fix this. I want my life back. The number one cause of untreated severe pain in the IC patient, the number one cause of severe pain in the IC patient population is an untreated Hunner's lesion. And those are the cases which really make me very upset, because we know that when you treat a lesion, the pain resolves in the vast majority of patients. And this is why whenever you're scheduled for a hydrodistension, you always have to have that discussion with your doctor before you go into the OR. Doctor, how are you going to do it? What's your method? Low pressure, short duration, hopefully. That's the way it's supposed to be done to minimize trauma. And then number two, if you find a lesion, how do you intend to treat that lesion? And if the doctor says, I'm not going to treat that lesion, you're going to say, why? And the answer is probably going to be because they don't have the equipment to do that. They might not have the equipment to do that, or the knowledge or the experience to do that. At which point in time, that is a kind of a step back going, oh, okay, now wait a second. I don't want to have this test again. I want a very clear plan from you. If you find this, how do you intend to address this? Because Hunner's lesions do not respond to oral medication. Hunner's lesions do not respond to Elmeron. Hunner's lesions do not respond to bladder installations. Hunner's lesions respond to lesion-specific therapy. And in the new AUA guidelines, they only have two recommendations. Number one, if you find tight muscles in that patient, they are to be immediately referred to pelvic floor physical therapy. None of this waiting 2, 3, 4 months. If they got tight muscles, we got a problem. We got to fix it. And number two, if you suspect that patient has Hunner's lesions and you find Hunner's lesions, you treat them immediately. You do not send somebody home to suffer for years because you lack the training to treat a lesion. And that's when you might have that conversation and say, maybe is there another doctor in your practice who knows how to do this? Tia says, what are my thoughts on InterStim? InterStim is a form of neuromodulation. It's a step 4 treatment option. In the old guidelines and the new guidelines, it is only to be considered if the patient has failed all oral medications and bladder installations. It uses a mild electronic pulse at the nerve to try to re-regulate the nerve. The challenge with InterStim is that it has a well-known history of many, many side effects, hundreds and hundreds and hundreds and hundreds and hundreds and hundreds and more hundreds of severe adverse events reported to the FDA. And it requires constant monitoring. So it's not a one and done. If you have an InterStim, you're going to have to go in regularly and get it checked, which means you're going to have to pay a copay for every appointment you go to, potentially. And for God's sake, you have to make sure it's covered by your health insurance. Get it in writing. Do not believe anybody who tells you it's covered. You get it in writing from the insurance company before you have it done, because we have had patients who have been lied to. They have been lied to. And after surgery, they were given $50,000, $60,000, $70,000, $80,000 bills, which they would never have done because of that. So, Tia, let me just do this here real quick. I'm going to tell you guys where I go to do this. So I'm going to open up a new web browser. Hold on. My computer's had suddenly gotten slow. What? Okay. Got the new browser open. I'm going to search for FDA. That's for the Food and Drug Administration. So I'm going to search for FDA space. You guys remember the old TV show called Maude? MAUDE. FDA Maude database. That is the manufacturer and user facility device experience. It is the FDA coaching. I'm sorry, not coaching. It is the FDA reporting process. I just got an email about coaching. Okay, so I'm now opening FDA Maude database. All right. It's not the ad, it's the first link. So now I've got it open, And I'm going to put in for the brand name Interstim. And then I'm going to look at the date. And so right now it'll search for adverse events reported in June. So from June 1st to June 30th. So let's look at that. Let's see what we got just from June. 268 adverse events reported in the month of June alone. See, they don't tell you this. They don't tell you about these adverse events. So let's go to the first one. Let's see what it is. Energy output problem. It's a malfunction, okay? And was there a patient injury associated with that? Doesn't look like it, but something happened. All right. Let's go to the next one. Inappropriate, inadequate shocks and stimulation. The patient was being shocked by the device as well as experienced urgency and incontinence. Let's just do a couple more of these. So again, we're looking at adverse events associated with the use of Interstim. Okay, this patient had a burning sensation, and they are calling this a malfunction of the device. All right. Let's go to the fourth one. Somebody with incontinence, another device malfunctioning. Let's go to this one. Surgical error. A lead was placed incorrectly. It had to be redone. So the patient was experiencing low back pain, cramping in the bladder, feeling her bladder filling up, and went to the ER. A patient has a follow-up visit and asked to go into surgery for a new implant. Okay. So regardless of the excitement that some doctors have about doing surgical neuromodulation, Interstim, they can do it at the sacral nerve or the pudendal nerve. You have to understand that there are hundreds of adverse events, including fatalities. The last time I went through the data was probably 5 years ago, 4 years ago, and I found 18 or 19 reported deaths associated with the use of Interstim. And the challenge with this public reporting database is you have the report, but you don't have the outcome. And they never come back and report the outcome of the patient. They never. So you'll see a lot of responses to reports like additional information requested, but it's never clarified. And so we, the consumer, have, just no good information on. I mean, it's just not good information. What we've got are many severe reports. We don't know what the outcomes of those were. So this is why patients often don't start with a surgical neuromodulation. They'll go to the ankle neuromodulation called urgent PC, post-tibial nerve stimulation, where there's no surgery involved. They just use an acupuncture needle as a vector to the nerve by the ankle, and they put a TENS unit on it. And there's no, I think the last time I looked, there were 2 side effects. Let me just, out of curiosity, let me just go back to the MOD database and let's just see if there are any adverse events filed for the ankle stim. I don't think there are. There were like 2 in 10 years because it's an acupuncture needle. All right, so hold on a sec. Let me just put in urgent PC and we'll do the same search. Hold on. Didn't mean to do that. Nothing for the last year. Not a single adverse event associated with urgent PC, the ankle stim. That's what I did. I was very lucky. I'm in California. Both InterStim and the ankle stim were invented at UC San Francisco. I'm north of San Francisco, about 80 miles. I was sent there as a referral, and I consider myself very blessed that I didn't end up in the InterStim group. I ended up in the ankle stim group, and I can show you here. Hold on. And it was the therapy that broke me out of a year-long flare. So let me see if I can. Let's see. There's a little black spot right there. I don't know if you can see that. Can you see that little black spot right there? That's the tattoo that they did. They then stuck an acupuncture needle into the spot, and then you have to kind of finesse it to get it to right to the nerve. The nerve is about an inch in, and then they attach a TENS unit to it. And when they turn the TENS unit on, if it makes your big toe, go down, or it makes the other toes splay out, that's when we know that the correct nerve is being stimulated. So I would continue strongly to look first at the ankle stim as compared to the surgical neuromodulation. Okay, hold on. You guys totally got ahead of me. W. San Marcos had 5 fulgurization surgeries for my hunters, and the last time I requested, he gave each lesion a steroid shot. I still do not gain any benefits. Are you saying, honey, are you saying that your symptoms do not change at all when they kill the lesion with heat, or when they give it a steroid? Are you saying that? I mean, that's interesting, and that's very, very puzzling, because when you kill the lesion with heat, you kill the nerve, and or you kill any viruses on the nerve potentially. So concept number 1, correct. Okay, so and bear with me here. Are you a man or a woman? I can't see your profile picture really well, and so I would address this differently for men versus women. So are you a man or a woman? I apologize. Just give me a hint here, okay? So we have 2 dominant theories here about lesions. Theory number 1 is that it's severe neuroinflammation of a nerve in the bladder wall. And the question is, how can that nerve become super, super irritated? So in women, we had a very interesting case a year ago of a woman who had severe Hunner's lesion disease, and she had a severe prolapse, like her bits were falling out of her body. And when they went in to surgically repair the prolapse, they found that her uterus was flipped back to front, front to back, because one of the tendons or ligaments, which normally hold it in place, was broken. And so her uterus was swinging. And so what that did is that created a strangulation of the tissue and the nerve that was affected by the swinging, twisting like that, right? So when they got rid of that and they restored her proper anatomy, her Hunner's lesions healed completely. And so understand that we think of IC not as a bladder disease anymore, but as a pelvic pain syndrome, because there are structures outside of the bladder that can be driving these symptoms. And that is a perfect example. It's called posterior fornix syndrome. Now, you don't have a uterus, but we had another interesting study last year that showed that 70% of men with chronic pelvic pain had an underlying hip problem. and they had to be referred to an orthopedic surgeon to see what was going on with their musculoskeletal anatomy, their skeletal anatomy in particular. And so that would be something that I would do in your case. Is I think it would be really, really interesting to see if there are any, especially if you were an athlete, where we have a history of pelvic trauma, or if you've ever had any bad falls, or if you were in the military, or if you're a football player or an ice skater or whatever. 90% of the men that I work with, we find a history of pelvic floor trauma, and that is the absolute truth. In my office, the men who call me, and I work with men every week, 90% of them have a history of injury. And understanding the toll of that injury is very important to understanding the toll of that to their pelvis and to their urinary tract. And remember, in the new European Association of Urology guidelines, they're not going to use any diagnoses ending with itis, cystitis, or prostatitis. They're calling it all pelvic pain syndrome. And if it's only sensed from one organ, it might be a primary bladder pain syndrome, or primary scrotal pain syndrome, or primary anal rectal pain syndrome, whatever. So I think it's very, very important to take a little bit of a step back and let's look at anatomy here for a moment. Is there anything else that's potentially going on that could be tweaking your nerves, right? And again, going back and thinking about your history, can you remember any trauma at all? Breaking your tailbone, falling on your tailbone? Were you a bike rider? Were you a motorcycle rider? Anything at all like that? That's important. Now, the other thing that's so interesting is that the Europeans also made a pretty important breakthrough with Hunner's lesions, because about 5, 6, 7 years ago, they were studying the urine of patients with Hunner's lesions, and they found a virus. They found a virus in the urine of some patients with Hunner's lesions. And it's not a sexually transmitted disease. It's not. It's a virus we all have called the polyomavirus. It's part of the normal human biome. But in patients who are immune compromised, the virus gets turned on, and it gets turned on in the bladder wall, where it causes bleeding lesions, hemorrhagic cystitis. And so the Europeans did a couple of studies where they consistently found this polyomavirus in the urine of patients with lesions, but not in the rest of us. For those of us who didn't have Hunner's lesions, they weren't finding it, right? And so we're like sitting here, you can go back 5 years in my online lectures here, and we talked about it all the time. And what was so interesting is that the American experts were being very quiet about it. And we're like going, guys, well, what do you think of the viral theory? What we didn't know is that they were doing their own viral study. As part of the MAP Research Network, the multidisciplinary approach to the study of pelvic pain network, which is funded by the National Institutes of Health. And they have urine samples from a sizable population of patients that go over time. So they went back and they looked at those urine samples. And what did they find? Polyoma. And in that small subset of patients, very small subset of patients, like 5% of IC patients had this viral infection in their bladder wall. And so that would be the other thing that I think is, you can come over to the IC network. I've got several articles on it, several blogs written about it. You can take that research to your urologist and say, what do we have to lose? Let's do a viral test. They can do a blood test, see if you have a virus. And if you do, then they might be able to do an antiviral. So he says, I've been bike riding for a few years, but I have a special seat that does not add pressure on the bladder, but you stopped riding 3 months ago. I think it was really smart for you to stop riding your bike right now. I do. I think I'd much rather have you walking, swimming, rowing, rather than doing something where we know that's going to be tweaking the biomechanics of your pelvic floor muscles and the nerves in your pelvis potentially. So I think that that was good that you stopped the bike riding for now. So 2 theories. Number one, it's a neuroinflammation from some sort of biomechanical thing happening in your pelvis, or it could be a viral infection. And at this point in time, we're guessing, and you deserve more than a guess. You need the facts. And so I would definitely take both theories back to your doctor. How old are you? Just give a decade. You don't have to give your last year. Are you in your 20s, 30s, 40s, 50s? There are also wear and tear injuries. That's something else that Dr. Weiss talks about in this book, that when we're young, our body and our muscles and our bones are very resilient, and we might not necessarily feel the toll of various traumas until we hit our 30s, mid to late 30s. That's when the wear and tear injuries really start to kick in. Yeah, I mean, it's interesting. All right, I'm coming back here to Facebook here. Sherry, have you tried the PEA yet? I think that it would be perfectly reasonable to try PEA, because we had the research study in 2019, which showed the palmitoyl ethanolamide, the key ingredient in this, reduced the pain in 87% of IC patients using it by month 3. And the general consensus among the researchers is that it's ideal for nerve-driven pain. So have you tried the Peoria yet? Kayleen said, would Botox help this incontinence? Well, honey, I don't know if it would help or not. My concern is, girl, you've been through a lot of trauma. And if they accidentally silence a nerve that controls your ability to pee, you're going to end up using a catheter for the next 2 to 3 months, until the Botox wears off. So I don't think I would go that far right now. We need to calm things down, my dear. Deidre says, what would I recommend for bladder pain flares? Deidre, if you come on over to the IC Network website, you can sign up for our free newsletter. You can do that on Facebook too, right on this main Facebook page. And our gift to you is a 40-page flare management guide that has hour-by-hour rescue plans, what to do for a bladder wall flare, what to do for a pelvic floor flare, and what to do for a stress flare. And they're completely different. You're going to treat bladder wall flares very different than pelvic floor flares. So come on over to icnetwork.org and sign up for that email, and you will immediately be able to download our flare guide. Or you can just buy our flare guide in our store too, or go to the flare management section of our website. Gayla said you had a small endometrial polyp. Could that create pressure? Maybe. Ann says, what is Urox for OAB? I don't know. I've never heard that before. It's a bladder control product, over the counter. It works to strengthen and tone the muscles of the bladder wall. What? That's pretty bold for a supplement. What the hell's in it? Muscles respond. There's no supplement that's going to tighten a muscle. What's going to tighten a muscle is muscle therapy. That's pretty bold. Concentrated herbal extracts. Horsetail, Crotava, Lindera. I got no experience with this at all. I certainly, there's going to be some people who would say, I'd rather take a pill than go to a physical therapist. I think that's a terrible mistake. Muscles respond beautifully to hands-on therapy. That hands-on therapy is so important. San Marco says, pelvic floor therapy is my next big focus. Good. good. I think that's, so if you had an office job where you're sitting for a long period of time, you never know. Angela says, hi, Jill, I'm late for the meeting. Wake Forest is starting a clinical trial for IC, something for people to consider. Yeah, they usually, I usually do clinical trial recruitment for them. I've got to send out a bunch of emails this week about it. Clinical trial, I don't know what it is. We'll have to find out what it is. Their last study, what they were asking for volunteers for the bladder replacement, where they actually would take a sample from your bladder and then grow a new bladder from that, and then replace your bladder with this newly grown bladder from your own cells. These patients had to have a big bladder capacity. Let's see, did I get that right? Well, you can read about it on our website. It's full now. We can't open it. I mean, there's no reason to submit your name right now. They'll let me know when they need more people, and I'll send that information out. Betsa says, what about when is urgency frequency that's not right? Frequency urgency is going to come from the irritation of the alpha afferent nerves in the bladder wall. This is the nerve group that works every day to tell you when you need to pee. It is an easy nerve to turn on, and it is a hard nerve to turn off. And so the first symptom that most patients experience with any sort of bladder wall issue is frequency and urgency. And the last symptom to go away is frequency urgency. So now we have to figure out how and why the nerve is irritated. Is it irritated because you have super tight muscles that is restricting blood supply to the nerves and the nerves are now inflamed? Or is it irritated because you're drinking way too much coffee and the acid is penetrating the bladder wall and triggering the nerve? Are you going through chemotherapy? Anything at all like that? So we're going to be targeting the nerve, but we have to figure out why that nerve is triggered. Gayla says, I'm confused about why my symptoms get worse as the day progresses. Well, a couple of reasons, but one of the most important reasons is something called pelvic congestion syndrome. If you, as the day goes on, feels like you're carrying a heavy weight in your pelvis, that it gets heavier and heavier and heavier until at the end of the day, it's like you've got a bowling ball hanging on in your pelvis and it's hard to walk. That's actually pelvic congestion syndrome, and that comes from varicose veins and blood pooling in the pelvis. And then you go to sleep, you lay on your back, the blood moves around, and then as soon as you get up the next day, it slowly starts to pool in the pelvis. So that concept number one. One of the other things that confuses patients is sometimes they have good days, but they always feel it at night. And that's because at night you have fewer distractions. Anissa says, what causes bad hip pain? It could be a muscle. It could be a problem with your bone. It could be arthritis at your hip joint. You've got to go talk to your doctor and try to figure it out. Does AV cause the bladder pressure and the feel of, wait, I missed that. I don't know what AV you're referencing. Gail has said, is a urologist or a urogynecologist better for care? Doesn't really matter as long as they have an interest in pelvic pain. Sherry is on the PEA. Good. It'll be, give it, again, month 3 is that critical point. So it'll be interesting to see how you do in the next month. John says, once nerve damage happens from muscle tightness, is there a supplement that will help the nerve heal? No, not that I know of. There are ingredients that can calm nerves down, like PEA, like lemon balm. Lemon balm has a nerve calming effect. PEA has a nerve calming effect. But understand that the reason why the nerve is injured is it's either a compression injury where the muscle is directly squeezing the nerve, or the muscle is squeezing the blood vessels, which is limiting blood supply to the nerve. And because the nerve doesn't have good blood supply, it can't be a normal nerve. It becomes an inflamed nerve. And so our therapeutic priority for that patient is to restore blood supply, and a supplement is not going to do that. Pelvic floor physical therapy is going to do that. That hands-on physical therapy is critical thing. Marcia says, any update on the NAC injections? No. Gayla says, do aloe vera capsules work? That's a really good question. You know, I've had this question a couple of times. So, because a lot of people have asked me, you know, what supplements would I recommend? And again, it always begins with your subtype, right? We have to understand the cause of your symptoms, and we have 5 core subtypes: Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and central sensitization. Those are the 5 subtypes that I use when I work with patients. And these originated from Dr. Christopher Payne, who ran the IC research program at Stanford. My voice is starting to give out, guys, so just so you know. Okay, so for patients who are bladder wall driven, not Hunner's lesions, but let's say the estrogen atrophy, the chemocystitis, so IC subtype 2, we're going to be looking first at chondroitin. Chondroitin is the most important ingredient at helping to restore the superficial integrity of the bladder wall. Okay, and that's what the research shows. Chondroitin is a building block of the mucosal layer of the bladder wall. And so if we're trying to provide a coating effect to the bladder, in my opinion, chondroitin is the most important ingredient to look at. Aloe is not a part of the human body. Chondroitin is a building block of the human body, right? So aloe is a plant. Chondroitin comes from animals. It's part of our system. So what aloe has the potential of doing is having a soothing effect. Aloe on a sunburn feels good because it's soothing. Aloe on an irritated bladder can be soothing, but it's not going to have the same physical effect that chondroitin will, because it's just not. It has a soothing effect. There are probably people who would disagree with me about that, but that is my opinion. And so a number of patients, I mean, we sold aloe for Desert Harvest aloe for years. I would be selling it today, but the company has a new owner and we couldn't come to terms, and that's fine. Desert Harvest aloe is a superb product. If you want to give it a shot, I think that that's great. The aloe that we have that I brought on is Aloe Path. And the reason why I like Aloe Path is because it has organic anthraquinone-free aloe in it, but it also has PEA in it for pain relief. And so what I wanted to try to accomplish is to improve the soothing effect of aloe. And I thought that combining aloe with PEA would give us 2 methods of action, both of which might be a little bit on the soothing side, especially the PEA over the long term. So, yeah, if you want to try aloe, go for it. Go for it. I just think that we have to try to understand what we want to try to accomplish. And for those patients with estrogen atrophy, the chondroitin is, in my opinion, the most important ingredient to look for, and you can always do both. In fact, there's another supplement that's called what's it called? I think I have it up here. Hold on. Ow. Here it is. Oh, I'm sorry. I can't believe I zoned on the name. So Cysto Renew. Cysto Renew, it is the first supplement that combined the chondroitin with the aloe with the lemon balm to calm the nerves down. So like the first chondroitin supplement was Cysto Protect, the second big chondroitin product was Cysto Renew, the third big chondroitin product was Bladder Rest, and then Bladder Builder. So there's just kind of been generations of product. The blessing here is they're just things you can try. Unlike 20 years ago when we didn't have anything, now we have things that you can try. And if aloe works for you, power to you. If chondroitin works for you, power to you. And so now Terry here brings up something important. Terry says, aloe seems to make my frequency worse. I keep hoping it would help and try, but I'm not sure. You know, and see, that's the thing is any supplement, doesn't matter where it comes from, any supplement has the potential to have adverse events. And there are some patients who are intolerant to aloe, and that's okay. If you're intolerant to aloe, we have other things that you can try. If you are intolerant to chondroitin, there are other things that you can try. So if it seems to be making your symptoms worse, and what the AUA says is if you're not responding to therapy, if you're getting worse rather than better, take a step back, revisit the diagnosis, reconsider the treatment, right? It's not for everybody. And Lori says, Sarah, I've been taking Desert Harvest Aloe for 35 years. It's been the one thing that has helped me the most. Awesome. Awesome. I'm pretty good friends with Pat Cressito, who started the company. Wonderful, wonderful lady. She and her sister started the original aloe company. So I've known them for many, many years. Marlia says, so if vaginal atrophy is a problem and estradiol cream is prescribed, is it right to add chondroitin supplement to use in addition with the estradiol cream? Sure, definitely. No, I mean, see, so it's like a Band-Aid, hon. Think about Elmeron for a moment. Elmeron, here, where's my thing? Okay, so this is one of the early Elmeron patient educational tools. And I don't know if you can see this. The way what they stated the mechanism of action of Elmeron was that it created a coating where coating was missing. And they used to have a little dump truck. Their little educational thing was a little dump truck that it was dumping Elmeron into the bladder where it would fill in these holes of missing gag layer, missing mucus. And you can see if we take this back and if we don't have that coating effect, the irritants in your urine can now reach these cells and cause problems. So coating effect. And so the same thing applies to the chondroitin. We also believe that the chondroitin has a similar coating effect. You know, because you're never going to have, Marlia, you're never going to have a 20-year-old bladder. You're never. We're older now. And even if we're using topical estrogen, I'm never going to have the really thick mucosal barrier that I had when I was a kid. And so estrogen will only get you so far. And having a little something that will provide a little bit of protection if you're struggling with urinary symptoms makes sense. The point that I'm really trying to make here, guys, and the point that I made in my GSM video is that I am heartbroken for those countless women who were told that they had an incurable bladder disease when in fact all they had was estrogen atrophy and that it wasn't a disease at all. It's all about the health of the skin. If your vulva's dry and your vagina's dry, so is your urethra and so is your bladder. And for the men watching this, this is just a separate issue that affects women far more than men. But we have to talk about it. Somebody's asking about that. So again, Allopath is the aloe that we now have. And I love it because it does more than just plain aloe. It's got organic anthraquinone-free aloe, but it also has palmitoyl ethanolamide to reduce pain. And we've got so many of our customers have switched over to this, and they're quite happy with it. It's very, very popular. So things change over time. We change over time. And the blessing that we all have now is that there are things that you can try. There are things that you can try. John says, does it chondroitin coat the bladder, or is it more of a building block? Kind of both. I mean, the challenge here. So what we would have to do is we would have to go back and look at the research for Uracyst. So in Canada and Europe 25 years ago, one of their key IC treatments was liquid chondroitin put into the bladder. It was called Uracyst. It was a bladder installation of liquid chondroitin. And so we had Uracyst, which was liquid chondroitin, and we had Cystitis, which was liquid hyaluronate. And they both had coating effects. And they are both approved in Europe and in Canada, but not in the United States. And I don't think that the chondroitin company tried to go through FDA approval, but I think the hyaluronic company did, and their data wasn't good enough, right? But long used in Europe and Canada as specific treatments for IC. And then what was interesting is somebody in Europe said, and so what was even more interesting is that the two companies were competing. And one would publish their research study and the other would publish their research study. We're the best coating, we're the best coating, we're the best coating. It's hysterical, right? But their data alone was never spectacular until somebody put them together as a coating of chondroitin and hyaluronate. It's called, the treatment name is called Ialuril, Ialuril, Ialuril. And the combination of the two was just stellar, far more successful than the individual ingredients. And so, again, like Elmer, so remember, the most effective way of giving the bladder a therapy is to put it in the bladder where it doesn't have to be digested. 100% of the medication arrives in the bladder and then eventually you pee it out, right? So again, the challenge with Elmeron, which also has that coating effect, is most of it, 92% at a minimum, is destroyed by digestion. Very little arrives in the bladder to have a beneficial effect, but some does. Some does. And so the assumption is that that same process is happening for the supplements, that some of it is getting to the bladder, but not all of it. And that's the difference between dietary supplements versus FDA-approved therapies. FDA-approved therapies, they have to put millions and millions and millions of dollars into completing these massive research studies that proves that their product is safe and effective and yada, yada, yada. Where the supplement companies, they don't have to go through that very rigorous research process. And that's one of the reasons why we don't have a generic Elmeron in the United States. Well, I mean, because the generic company has to reproduce all those original studies, costing them millions of dollars. So we're in a dicey situation here. I mean, we would love to have more data, but there's no company that's going to pay for that data, for the $10 million, the $20 million that it would give us to give us a really good bioavailability study. So it's informed guesses supplemented by a variety of research studies. This is, you know, the IC movement is alive and well. The research movement is a fabulous research team that is continuing to help us understand all the biomechanics of what's going on and giving us so many big clues as to why certain things are happening to certain people. But there's one thing we absolutely know is that we're not all the same. There's diversity. For some patients, it's pelvic floor driven. For others, it's Hunner's lesions. For others, it's estrogen atrophy. For others, it could be a viral infection, right? And so we're subtyping now. And the challenge with subtyping is that it's going to dilute interest from pharmaceutical companies to want to invent new treatments. And so we do not have a viable candidate nearing FDA approval for any new therapies at this point in time right now. Not that I'm aware of. Not that they've told me, but usually I hear about it. Usually I hear about it from somebody or another. So Marco says, when I start pelvic floor physical therapy, how long on average will I need to see a therapist in the office? I don't know how long my job will cooperate. I'm a manager in catering. I will need to take. Well, it depends upon what they find, hon. That first appointment is going to be your pelvic floor assessment. That's about an hour-long appointment, and they start externally. They're going to look at how you walk. They're going to have you walk up and down hallways. They're going to look for tension patterns in your back, in your core, in your glutes, in your belly, et cetera, et cetera. You have to be able to walk into that appointment. Please don't walk in and say you have IC. That would be a terrible mistake. You need to walk in and talk very specifically about your symptoms. These are my symptoms, and the devil is in the details. The weirder the symptom, the more important it is you tell them about it. Do you have a vibration when you sit down? Do you ever have pain that shoots to the left or shoot to the right? Where is the pain located? Is it centered to your crotch? Is it to the left or right? Is the pain shallow or deep? Is the pain on your skin, or is it deep inside of your body? Do you ever have pins and needles? Do you ever have areas of numbness? What is the quality of the pain? Is it sharp? Is it dull? Is it electrical? And their job is to study your anatomy. And they start externally, and then they will request a chance to do an internal exam. It's be a rectal exam, no worse than a prostate exam. All they're going to do is touch muscle. They're just going to touch muscle groups. And if they can touch a muscle group and trigger your pain and discomfort, that is what I call your hallelujah moment. That is very exciting because it means they found it. They found it. And your immediate question is going to be, that's it. What are you touching? And what I want is for you to be able to walk out of that appointment with the name of the muscle or the muscles, plural, that are causing and contributing to this. And again, listen, if they say, man, you are tight, you have to get this book. Because it's very, very important that you understand where structures are and how they influence each other. And there's a chapter in here. Let me see if I can find it real quick. The reason why we want you off of that bicycle seat. Hold on. I got to find it. You would think that I would have paper clips on all these pictures, but there are so many. Let me see if I can find this. Hold on. Understand, too, that the only way they can touch these muscles is internally. They cannot reach these muscles externally. And so it is really important that you not, get upset about that internal rectal exam. It'll be quick and it'll be enlightening. All right, come on. I got this great picture. Hold on. Oh, here it is. Okay, so let me give you a little. Let me give you a little insight here. This book is amazing. Okay, so when I read books, if I'm really trying to absorb it, and I love school, so that was fine. I study and I use a lot of markers and a lot of colors. So I want you to look at, even though this is female anatomy, this still applies to you, San Marco. I want you to look at the nerves. Look at this webbing of nerves that go from front to back, okay? So here we have our sit bones, and in between our sit bones, in your crotch, we have a lot of nerves in the skin and directly underneath the skin, right? Now, I want you to look at a bicycle seat. Okay, so here's the bicycle seat, right? And you can see the bicycle seat immediately pressuring the nerves as they're coming out of the sacrum. You see that? Bike rider syndrome. We call it bike rider syndrome. A narrow seat provides insufficient cushion space to support the sit bones properly. Therefore, you must balance your weight on that part of the pubic bone to which the genitals are attached, under which the clitoral and penile branch of the pudendal nerve travels. The delicate nerve fibers can be traumatized anywhere along this route, causing pain or numbness if they are compressed by a bicycle seat. Horseback riding can do the same, habitually sitting on hard, uneven, or uncomfortable surfaces. Some surgeries, like a gynecologic, urologic, proctologic hip surgeries, can traumatize the nerve. Chronic constipation, sagging pelvic floor, pain referred to the pudendal nerve, a stressed obturator internus or piriformis muscles, and tight pelvic floor muscles. This book is the bomb. I love it. I love it. I love it. I love it. I love that, doctor. Gayla says, what product has chondroitin? There's 4 basic products that have chondroitin. Bladder rest. And this is kind of the starter formula. It's in an avocado oil base. Bladder builder. And then I do not have a bottle of Cystomend. Hopefully I'll get one. And then the last one is Cystoprotect. Cystoprotect is the tried and true. It's been out for well over 20 years. It went through a debacle of cancer warning on it that's long been resolved for 2 years. But a lot of people walked away from Cystoprotect because of the cancer warning, even though that's been fixed. And ironically, titanium dioxide, for those of you who know, titanium dioxide is a white food coloring that is used in a lot of food and a lot of tablets and candy and stuff like that. We just had a lawsuit filed against, was it Skittles? Because they kept titanium. It might have been Skittles. It might have been another candy where they kept the titanium dioxide in the candy, and now they are being sued for potentially causing harm because the nanoparticles of the tiny particles of titanium dioxide travel throughout the body, including to the brain, where they can cause cell death. And that's what the research has shown. That's why we don't want to use anything with titanium dioxide, and that's hard because titanium dioxide is still legal as a food coloring here in the United States. However, it is now banned in Europe. Gayla says, what can we drink other than water? Well, you can do milk. You can do chamomile herbal tea. You can do peppermint herbal tea. You can do, this is an herbal coffee, iced coffee made with Dandy Blend. Love this stuff. Love, 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 love this herbal coffee. It's called Dandy Blend. It makes great lattes and it makes great iced coffees and great frappuccinos. You guys know I drink it almost every day, 2 or 3. Sometimes I blend it up with frozen bananas, but I do at least 2 or 3 of these a day. Never flared from it. There's no acid in it, no caffeine in it. Perfect for somebody like me. Lori says, have you heard of anything about immunosuppressants in current research for the bladder? My urologist mentioned that he says may be available in a few years. Well, cyclosporin is an immunosuppressant, right? And so for some patients, cyclosporin, even though it's a beast of a medication to take, it had some pretty significant risks of adverse events like high blood pressure. For some patients, is a bit of a miracle drug. Hi, Loretta. Just an update on estradiol for estrogen-driven breast cancer. My oncologist isn't happy, but understands vaginal atrophy and approved estradiol cream 2 times a week at a low dose. Yeah, baby, there you go. And that's the research supports that. Oh, I'm so glad. You know, just a little tiny bit. Now, I was at a conference. So I was at a conference last year, and I don't remember which conference it was, and it was virtual. But there was a doctor who was talking, it was a female doctor, and she was talking about to reduce the risk of absorption with estrogen, topical estrogen for patients who do have a history of cancer. And what she said was, if you have that worry, then using it externally on the vulva and maybe at the entrance to the urethra will result in less absorption than if you used it in the vagina. And that was the first time I'd ever heard anybody say that. I mean, the research is really clear. The research says topical estrogen stays in the skin. But if we want to go into detail, it does kind of make sense that maybe more of it would be absorbed vaginally, especially if that patient has, you know, some sort of vaginal abnormality or even severe estrogen atrophy, then more of it's going to be absorbed. So don't ask me who said it and don't ask me what conference that was at. But I remember going, isn't that interesting? It was probably the International Pelvic Pain Society conference. I don't think I could find it, though. Marilyn says, can a 7-year-old have IC? What do you know about PANS? Yes, a 7-year-old. I had my first symptoms when I was 12 years old. I've worked with a number of moms who have young children who have the symptoms of frequency urgency pressure pain. Now, so again, Marilyn, we don't think of IC as a bladder disease anymore. We don't. We think of it as a pelvic pain syndrome, injury, trauma, and that's especially true in younger patients. I'm trying to remember. This was yet another. Okay. In the last 6 months, I was either listening to a conference or I was reading a research paper where a doctor, and I think it was a paper, where a doctor said for somebody who developed IC under the age of 20, we're really looking at injury. And so that's when an injury to the pelvic floor, falling on your tailbone, and think about a 7-year-old. They do a lot of falls. I mean, there's a lot of falls. Riding a tricycle, riding a bicycle. How many times do they fall backwards onto their tailbone? And We would also want to look for exposure to cigarette smoke. We have very clear research that has now connected cigarette smoke to the development of bladder cancer, because all of those toxins, the 10 or 20,000 toxins from every inhale of cigarette ends up in the urine. And, God forbid this is somebody with estrogen atrophy, then you're given those carcinogens direct access to the cells, which is a terrible thing to do. But for that young child, when they breathe in that smoke, we have research that now proves that young children can have all of the symptoms that we associate with IC: frequency, urgency, pressure, pain, from the toxins in cigarette smoke irritating their bladder wall. So that would be the second thing that I would be looking at. And I can give you that research if you want that research. We've talked about this during IC Awareness Month several times. We've had press releases on it. And then last but not least, we also want to look at the concept of bullying and abuse. We now know that patients who develop chronic overlapping pain conditions, they might have bladder issues, and then they might have bowel issues, and then they might have TMJ, or they just migraines, whatever. We now know in that research that their brain is stuck in fight or flight. They're living with 24-hour anxiety. San Marco, yeah, you get it right from the IC Network. It's $6 cheaper than Amazon. So we know from that research that that brain is in a constant state of fight or flight. And the International Pelvic Pain Society had a conference dedicated to this 2 years ago. It was a fabulous conference, did a huge article on it. If you want to email me, I can send it to you. My email is icnetwork@mac.com. They did, what's the right word for it? In trying to understand why this was happening to kids, they looked at their history. And what they found was that 80% of the children who developed multiple pain conditions sustained a major physical injury, getting hit by a car, broken leg, broken bone. We know that 14 days of pain will put that brain into a constant state of fight or flight. So 80% of the children who developed this pain had a major physical injury. And of course, the tragedy here is that children are not able to verbalize that they're in pain, or if they do, they are often discounted by doctors, discounted by parents. I was working with one who literally had like a broken vertebrae, and she would cry every time she laid down. She was in high school. And it took 3 weeks before her mom took her to the doctor, and she actually had a broken back. So we certainly know that children are, when they are in pain, are not necessarily listened to. So 14 days of intense pain will trigger this fight or flight. But for the other 20%, it's a history of abuse or bullying. And that makes sense. Let's just say that your 7-year-old has, they're in first or second grade now. Let's just say that there's a kid at school who is a terrible bully, and they hit them. I mean, this is what happened to me. I mean, I have no shame. I will talk about what happened to me, and that is I grew up in a neighborhood with a kid who later raped and murdered my neighbor, severely mentally ill as a child. Many of us were hurt physically. I was hurt physically. And from 4th grade through high school, whenever I left my house, I went into guarding it and fight or flight, because it was that bad. My neighbor was raped and murdered. And so imagine what that did to my brain. Normally, you go into fight or flight temporarily if there's a saber-toothed tiger across the street. 20 minutes later, 30 minutes later, an hour later, your brain changes. Parasympathetic nervous system takes over, calms everything down, you're good. But extended periods of fight or flight change the brain, and they change pain processing. There's great news, though. We know exactly what to do to turn it off. We know exactly what to do to turn it off. And that's a good mind-body medicine, good sensory information. You can't think yourself away from this pain. This is all about proving to your brain that you're safe with good sensory information. What do you see? What do you hear? What do you smell? Et cetera, et cetera. And I can go over that if you'd like to do that. So anyway, so we got 3 theories. Number 1, major physical injury. Number 2, exposure to cigarette smoke. And then number 3, is there a history of bullying? Is there a disease process happening? Unlikely, but that's certainly possible too, and they have to rule that out. Especially if you have like a common, so let me take that back. If you have a bathtub with jets in it, and if those jets are installed improperly, the jets in the bathtub are supposed to be at a slight downward angle, so any water that gets into them drains out. If the jet is horizontal or this way, water accumulates in there and it becomes a bacteria factory. And so bathtubs are absolutely associated with infection. So I would hope that they would have already ruled that out too. So Loretta says she okayed the vaginal Valium at a low dose. You have to weigh the pros and cons. It was a decision not made lightly. Exactly. Loretta, if you can, do me a favor and go watch my estrogen atrophy video, and let me know what you think of it. Okay. I mean, I put it up on YouTube last week. It's on the IC Network website in our Living with IC videos. I'd love to hear what you think of that. See if I covered that well from your perspective. Nancy says, what to do for estrogen atrophy? Your doctor says no more estrogen, says it makes you more susceptible to blood clots. Well, then, you're really not going to have a choice. You're going to be using coconut oil or V-Magic externally to protect that skin, because dry skin is bad. Mucous membranes are meant to be wet, and it's not water. It's a gag layer, glycosaminoglycan, which is actually kind of a sugar oil layer. And so doing something like V-Magic or coconut oil externally will help that skin, because we don't want it to be dry. If you're getting that burning while you're peeing, it's dry, right? Let me get that in there so you can see that again. And then internally, we used to have a vaginal moisturizing product made by, it starts with an L. Some patients found it irritating. Hold on. Let me look. Luvina. Luvina had a vaginal moisturizing insert that you could potentially try, but some patients found it a little bit irritating. If you're going to have sex, you're going to need a lot of KY, a lot of moisture, just to give yourself a little bit of lubrication there. And then for your bladder, you're really going to be looking at the chondroitin-based supplements. Jennifer says, what's my thoughts on platelet-rich plasma? We have more and more doctors that are doing it. We just don't have a lot of data yet. Marilyn says, my 7-year-old granddaughter has frequent urgency. Her had her tonsils removed. Anyway, she has 30 minutes, frequent urination, going to the bathroom, has to wear pull-up. No doctor can get to the bottom of it. I'm the grandma and it hurts me. Well, Marilyn, again, we have to look at food also. I mean, because she hasn't gone through puberty yet, so she doesn't have a lot of estrogen yet, so her skin may be a bit more vulnerable down there. You guys giving her a lot of juice, a lot of soda, stuff like that? That's possible, especially when you have your tonsils removed. You're given ice cream and soda for a week. They were talking about removing my tonsils because I have tonsillitis for the first time in my life. San Marco, go to our store. Up in the menu on the far right hand link is the ICN shop. Click on that and then go to books. But you'll see it right on the cover. You'll see right on the front page of our store, which is a different website, but you can get to it from the IC network. It's icnsales.com. icnsales.com. Gayla says, can we drink stevia or have a decaffeinated root beer? Not every day, hun. The artificial sugars, we just don't have enough data on the artificial sugars and how they're metabolized and if they cause long-term irritation. So aspartame, we certainly do know is a problem. Stevia, we just don't know. We just don't have a lot of research yet. At least I'm not aware of any research. I haven't looked into it in the last couple of months or the last couple of years. Decaffeinated root beer, of all the sodas, root beer is going to be the most bladder friendly. A natural root beer that's naturally caffeine free would be great. I would drink it on ice, so you have the water to dilute it, and I wouldn't do more than one a week. And I certainly wouldn't do it if you're having symptoms. And if you have Hunner's lesions, no. Loretta, you're right. Nancy said she recommended Replens for moisture. Yeah. It's just, you got to do what you got to do, hon. If you're feeling dryness down there, then that would certainly give you a sense of relief. Marilyn says, why is my 7-year-old granddaughter urinating every 30 minutes? So again, is her bladder being irritated by something that she's drinking every day or eating every day, Marilyn? That's like number one. Number two, is there any history of injury, traumatic injury? Is there any history of bullying? Any of those can potentially cause some of the frequent urination. Hold on a second. They're saying pediatric acute onset neuropsychiatric syndrome. How unfair is that? That's very unfair. Marilyn, if you'd like to talk later this week, give me a phone call. I'd be happy to kind of go through some stuff with you and maybe I mean, that offends me. It offends me because it happened to me when I was in 7th grade and I couldn't sit through class. It was, oh, you'll outgrow it. Oh, no, maybe there's a problem. Oh, maybe you have infection. When, again, we now know that it's not all in our heads, that generally we see injury, trauma, and it can be a pelvic trauma. She could have fallen on her tailbone and caused this. She could have drunk cranberry juice and caused this. There can be a number of things that can lead to increased frequency urgency. And the PANS, it really offends me. That really offends me. That's so easy to say, oh, I mean, this doesn't just happen to children. It happens to adults too. This goes back to the 50s when a couple of researchers published a paper in which they claimed a woman with IC had unexpressed anger manifested in the pelvis. And from like 1958 to like 1980, medical schools taught doctors that this was a mental and emotional disease, and it's not. And we've since, our federal government has spent well over $100 million on this. It's certainly not all in their heads, but there are real things happening. This is a real condition. So anyway, all right, guys, listen, my throat's done. It is done. I'm not going to talk for another 2 days now. Holy moly, is it done? So I'm gonna be done. If you found this conversation helpful, this support group meeting helpful, please come on over to the IC network. consider becoming a member so that you can get our magazine. I put our heart and soul into this magazine to give you the best information that we can. You can buy all the supplements over on the IC Network. You can make a donation if you found that helpful. Times are tough for all of us, and times are tough for the IC Network now, too. The recession is hitting us all very, very hard. So rather than going on over to Amazon and buying your stuff, come on over to the IC Network because it's cheaper anyway. It's cheaper anyway. So, all right, guys, I got to sign off. My throat. San Marco, did you find the book? Do you want me to give you a link to it? Here, hold on. It's always scary, you know. There's just a lot of uncertainty right now. May the rest of 2022 be it's just a crazy time. I mean, seriously. The stress that we have all been under for the last couple of years seems to be hitting particularly hard in 2022. And so be kind and gentle to yourself. Take breaks when you need them. I took a break. I will probably still have to take some breaks. And let's just be gentle and get through all of this together. Keep wearing your mask, please, to protect your bladder from COVID. All right? Okay, guys. I'll see you later. Have a good one. Oh, my throat. Yikes. Oh, I'm so glad. I'm so glad you found it. I'm sure you'll find it helpful. All right, YouTube. I'll see you guys later.